I want to talk a little bit about the design of the registry and why it's a patient registry, right? So many of the registries that we build or you've been involved in are both patient-facing as well as provide clinical information. But this particular registry made a conscientious decision to really focus on patients and their lived experience. I remember early on talking to patients, their families, well, more so to families and caregivers, and to the physicians. And what was very interesting for me is that, as somebody who's not an affected person, understanding the implications on the time that these families have or the time availability. The fact, one mother said to me, when I have to enter data, I can't do it when my child is seizuring. I have to hold them with one hand. So I need a device or a mechanism to enter data with one hand. And those are the things that you learn from patients. But I guess, question for you, you've already talked about the multiple languages. Let's talk a little bit about why this is patient-facing and why it's so important to start there.
Yes, absolutely. And to your point as well, Femida, there was a similar comment that we got back from the patient community that, for instance, the original forms might have been set up so that you needed to complete the whole form before hitting save. But your team worked with us, the Pulse Infoframe team worked to allow for pauses because moms and dads were saying, what do I do if my child does have a seizure and I have to stop and go away? I come back, I could lose my work. And so that flexibility in working with the Pulse Infoframe team on optimizing the platform to make it as sensitive to the demands of the families, I think is absolutely key. What's so critical for us with the patient family reported data angle approach is that this disorder is a truly challenging neurodevelopmental disorder with disruptions in many different aspects of the child's life. Sleep, eating, all aspects of social interaction, and those are very hard to capture in a clinical setting. The experience of a clinician who maybe would visit with the child once every 6 months for 15 minutes to a half an hour cannot adequately capture the real lived experience of this disorder. And it's so important for us to understand it, not just the nuts and bolts of the disorder, but more importantly, how they change over time as the child ages. How does this change as a child passes into puberty? How does it change as the child really gets into adulthood? Nothing along those lines was known about this disorder and what an effective therapeutic would actually mean. And we certainly want to underscore that because for many people, maybe those not so versed in or experienced in CDKL5 deficiency disorder, they may assume that the epileptic seizures are the end-all and be-all. In fact, what we learned from talking with the parents around the world, from everywhere, was that the seizures are something that they manage, but for them, the truly important aspects are the lack of communication with their child, the challenges in social interaction, and the challenges of the lack of autonomy for their child. In learning from the families by collecting this sort of information, both in questionnaires and through the formal registry, we're actually able to learn more than we would if we had just been looking at a straight clinical approach to this, to the understanding the disorder.